Yeah.
Okay, Nasir, can I start?
We can start.
Good evening to all viewers. I wholeheartedly welcome you all for this interesting session from IAP ID Karnataka chapter. Myself, Dr. Naglata, Secretary of ID chapter, welcome you, along with Dr. Ravi Shankar sir, who is the President of IAP ID Karnataka state chapter, for this interesting session. Session will be introduced by our eminent speakers. Before that, I would like to thank Central IAP, President Dr. Piyush Gupta sir and Dr. Basuraj sir for their constant support for all our academic activity, and also the ID residents, Dr. Yagnesh and Dr. Kaya madam, for the opportunities and the academic support they are giving. This program is being held in association with IAP Karnataka chapter. So I wholeheartedly welcome and thank Dr. Ashok Dattar sir and Secretary Dr. Amaresh for this wonderful session. So we have been listening to so many sessions, so many things about Corona. This is an off topic and an interesting one to throw insights into disaster management, what we could probably do. So Dr. Ravi Shankar sir has chosen one of his best friends and people from eminent doctors from Texas. They will share us with us experiences, what they have been doing. I welcome all of you for this session. Special welcome to Dr. Sumita madam, who is the EB member, Central EB member. Jagdish sir, welcome to the session. Welcome all of you, all the senior pediatricians here. We have two eminent speakers, Dr. Suresh Gautam sir. I need not introduce sir. Sir was here for all our IIP BPS program for a long time. Sir's PG program were very popular. His statistics classes were very well taken, and students still ask the recordings of those sessions. I welcome sir. Dr. Suresh Gautam sir is the professor of pediatrics in Baylor College of Medicine, section head and service chief of neonatology, Texas Children's Hospital. Sir is the editor of Goldsmith textbook of neonatal and associate editor of neonatal review group of Cochrane collaboration. Sir has innumerable publications, and sir is journal reviewer. Sir's CV went on for 34 pages. I am not sure what to pick and what not to pick. This is all I could summarize. Sir, welcome you to this session, and sir will be moderating this session with one of the most eminent speakers from Texas. We welcome Dr. Kesni. Am I right?
Kazini.
Kesini, Dr. Kesini. Welcome you, sir. Dr. Kesini is the Medical Director of Emergency Management in Texas Children's Hospital, Assistant Professor, Baylor College of Medicine, Co-Director of Disaster Domain for Emergency Medical Services for Children, Innovations and Improvement Center. Sir has many publications to his credit. Sir has been awarded the Hurricane Catherine Code Gray Award, Hero Award in 2005. I welcome you to this session, and I hand over this session to Suresh sir for further introduction and carry out the session. Welcome Dr. Geeta Patil madam for this session. Yeah.
Thank you, Dr. Naglata, Dr. Ravi Shankar, Dr. Sumita, for inviting us. Can you hear me okay?
Yes, sir. We can hear you, sir.
Okay. I will just give a brief introduction and welcome, and then I will hand over to Dr. Kazini. As most of you know, I am a neonatologist, and I've done a lot of clinical training and I've done a master's course, but nowhere in the training did I formally undergo any training in disaster management. So I did a DM course in PGI, but I never did the other DM, which is disaster management. And we have a PAS abstract right now where we surveyed leaders during the COVID pandemic, and we found that only 20% of leaders had formal training in disaster management. So one of the goals today is to share some theory and some principles of the science of disaster management using examples from our own practice. And really my experience with disaster management came about in 2017 when we had a big hurricane hit Houston, where Dr. Kazini and I work. And I just want to show a brief video for 2 minutes about what that experience was like. Give me 1 second. Can you see the video online?
No, sir. No. You please, when you're sharing, include the audio from the computer also. Then that sound also will come. Click on that. It is on the right upper corner, right upper hand.
How about now? Can you see the video?
Something has come, but the video is not running. Continue without audio. No, always allow. Always allow. Click on always allow. It came then.
Okay.
Why it not coming now?
Let's not get focused on this. Let me pull up the video later. I want to get to the actual session. So just a couple of housekeeping rules. Dr. Kazini and I are not here to give you advice or tell you what to do in Bengaluru or Karnataka or India, because we're not the experts about what is happening locally with the pandemic. You are the experts, but we want to share our knowledge and what we have learned from managing disasters. So like I said, we had a big hurricane and huge flooding in Houston, which was devastating. And in 2018, learning from that experience, Dr. Kazini, I, and a couple of other neonatologists conducted a workshop at the PAS meeting on disaster management. And that's why I got to know Brent. And I can tell you he's an expert and a great speaker, and you're going to learn a lot from him. The other thing is we want to have a lecture followed by a long discussion and question and answers. But in the discussion section, I do not want us to spend time criticizing how the system has failed, criticizing the government, or finding fault or assigning blame. I want us to truly make this a learning session to see what we can learn that will help us tomorrow, tonight, manage the situation in India right now. So with that background, I'm handing over to Dr. Kazini. So Brent, take over, and the forum is yours.
So you have to stop sharing, Gautam. Let him share.
Is that good?
Yeah, he can share now.
Hopefully you all can see my slides.
Yes, we can see your slide, Brent.
Well, thank you for that introduction and for the opportunity to share with you all some things that are, I find to be extremely important in framing, I think, the discussion in response to any disaster, as well as kind of getting prepared for any disaster. And again, I think one of the important things that Dr. Gotham highlighted here is really the gap that we've identified in training in this area for physicians. That's something that I think we have recognized is not embedded in really any residency training program here, in particular for pediatrics. And as such, we've recently in the past year launched a disaster medicine elective for our pediatric residents to give them and share with them some of these basic emergency management principles. And while obviously I'm going to touch on the pandemic, really a lot of this is much more global in its approach to specific, I would say, not just disaster medicine, but emergency management, which I think is something we should all have somewhat of a focus on. I do have some financial disclosures. I received grant funding through a couple of sources. One was mentioned in my introduction. Thank you for that introduction. Via the EMS for Children Innovations and Improvement Center, where I serve as the co-director of the disaster domain. And then recently, in the last couple of years, the Assistant Secretary of Preparedness and Response here in the United States funded 2 pediatric disaster care centers of excellence. One is out of California and supports a number of the states surrounding California, and the other is in Ohio and Michigan. And I'm embedded in the work group working in the Ohio-Michigan group. And I've somehow become, I guess, the quality improvement expert in disaster medicine, which I have no formal training in quality improvement, but I've done a number of projects in that area. And it just goes to show you, I think, the increased need for work in this space. My personal goal is really for everyone to be involved in emergency preparedness and planning at all levels of the institutional response, but also really thinking about yourselves as individuals and what degree of personal preparedness you have embedded in your own families and in your own lives. And so I'd like to really start just by saying, are you prepared for disasters? As physicians and as clinicians, it's of the utmost importance that we ourselves have our own homes in order so that we can respond to these events. As Dr. Gotham mentioned, when Hurricane Harvey hit Houston, I'm expected to be in the hospital for a long period of time during what we call our ride out, when we bring everybody into the hospital that we need to stay self-sufficient during that time period. And that would be hard to do if I didn't know that my family was safe and my family had the necessary, supplies and things that they need to stay safe during that event. So this is actually the cover of the Family Readiness Kit that's been developed by the American Academy of Pediatrics. It's a tool that I helped create a couple of years ago, and it's available online at the American Academy of Pediatrics Children in Disaster site. But it does a good job of framing family readiness for our patients and their families, but also for ourselves. And I recommend that that physicians take a look at this, because it might give some introspection into what you might need to be better prepared to respond to a disaster in your own home. I do want to share a little bit about my background and what brought me to this work. I actually did my medical training at UT Houston down the street from where I now work, and started my pediatric residency in New Orleans at Tulane Hospital in downtown New Orleans.
Brett, can I interrupt for a second? I'm getting messages that your voice is a little faint.
Oh, sure.
Can you get closer to the microphone?
Sure. Is that better? I can try to speak up too. Is that better?
Yeah, speak up and stay close to the microphone. Yeah,
okay.
Go ahead. Sorry.
That's okay. I'll try to make it closer. Hopefully this is better. So I do want to share with you a little bit about my background. I started my medical training at UT Houston as a medical student, and then was in New Orleans during Hurricane Katrina. So August 28th of 2005, I found myself on call on the pediatric floor at Tulane Hospital in downtown New Orleans, and was there during the evacuation of patients from both Tulane Hospital and Charity Hospital, which is positioned across the street from Tulane Hospital. This experience was really a life-changing experience for me, as I saw a number of system challenges that were faced and that I felt that could have been handled much better, even with my limited training and experience. And so through the rest of my residency and fellowship training and beyond, I've sought out opportunities to learn as much as I can about disaster medicine and emergency management. Here at Texas Children's, I think we have a rich history in disaster preparedness and emergency management principles. For those of you that are not familiar with Texas Children's, we always say Texas Children's Hospital, but it's much more than just one hospital. While we do have our medical center location, which is the largest children's hospital in the United States, we also have 2 community sites. And while they are community sites, they are very busy freestanding children's hospitals with pediatric ICUs. One has a neonatal ICU as well, and another one has our special isolation unit, which is an 8-bed biocontainment unit that we created in the aftermath of the Ebola, or during the Ebola epidemic in 2014. As I mentioned, emergency management at Texas Children's has a rich history, and it's one of the reasons that I decided to come back here after my fellowship training and pursue this work here. It's because I know it's something that the institution is dedicated to providing resources for. And an example of that is this picture here. So you may not know what this is. It looks kind of like a submarine door, but what it is a flood mitigation door. In the Texas Medical Center, all of the hospitals are connected by underground basement level hallways. And Texas Children's installed 6 of these flood mitigation doors at great expense to the institution, but very forward thinking. And 6 months after the installation of these was Tropical Storm Allison, which was a tropical storm that essentially hovered over the Texas Medical Center, flooding much of Houston, but in particular the medical center, resulting in the closure of multiple hospitals within the TMC. Texas Children's was the only hospital that was able to provide full functions during that event as a result of those flood mitigation doors that had been installed. Since then, more of those flood mitigation efforts have been put out throughout the entire TMC, and per FEMA, it's arguably the most cost impactful flood mitigation, disaster mitigation effort that's ever been done in a healthcare setting, as it provides us the ability when flooding occurs to continue operations throughout the Texas Medical Center. So Tropical Storm Allison, as you can see here, dropped 38 inches of rain and again primarily targeted the Texas Medical Center, resulting in widespread flooding throughout the city, but especially the medical center. Fast forwarding to what Dr. Gotham mentioned, Hurricane Harvey years later flooded the Texas Medical Center as well. This is a photograph from that. And again, we were able to maintain operations in due large part to those flood mitigation efforts and the efforts of emergency management and folks like myself in better aligning the physician response to what the hospital does. So one of the key things that I think is really important for institutions to do, and this is something that is here in the United States is a joint commission requirement for hospitals, is to conduct what we call a hazard vulnerability analysis. And this is a joint commission requirement, so it's something that's required that all hospitals do, but we kind of go above and beyond that minimal requirement and perform HVAs for each of our freestanding hospitals, as well as our large network of outpatient clinics and urgent cares and our health plan. This tool was initially developed by Kaiser Permanente, and we've tweaked it a bit to suit our needs, but really what it does is assists you in identifying what risks your facility is at risk for succumbing to in the event of a disaster. And it just highlights the importance of what you need to focus your energies and efforts on. But it's something that could be scaled to any sort of clinical setting, from a hospital to an outpatient clinic to even your own home. What it looks at is what the event is and the event type, but then breaks down probability, severity, so the magnitude, and then mitigation efforts to identify a list of what your true risks are. So I'll talk through this briefly because I think this is an impactful tool that assists us in identifying what our risks are and where we should push our efforts over the following year after we've completed this. So again, as I mentioned, the first column is really what the event type is. So here you see the event type is active shooter. That's a man-made disaster. And then we look at the probability of this occurring. So we see, has it never happened, could never happen here. So if it was something like a volcano eruption, that's going to get a 0 for Houston. Low, it could happen here or has happened here. Moderate, it has happened here in the last 5 to 10 years. And then high probability, it's happened within the last year. And for the sake of our medical center campus, we use the Texas Medical Center as our catchment area for saying whether or not an event like this has occurred. The next group of columns is looking at the human impact, property impact, and business impact. And in particular, looking at the human impact, is this something that may cause death? Is this something that can cause injuries, minor injuries, or no human impact? Property impact, looking at, is it something that could completely destroy the property? Is it something that's going to cause major impact to the property? And then looking at interruption of services, is this something that can completely immobilize patient care services where we would have to shut down all clinical operations or have a major impact, but not completely immobilize things? And then that final column, so these things are all relatively static with the exception of probability. For active shooter, human impact is not likely to change. If it's a 3, it's going to be a 3 year to year. And property impact will be a 1 year to year, and business impact will be a 3 year to year. But where we can push efforts to improve things is in this final set of columns, looking at pre-planning, our preparedness level, our internal response, and our external response. So what we see here is our preparedness, or what kind of plans have we put in place, what type of training have we done for the members of our staff. Our internal response would be things in particular for active shooter, like what is our security presence like? What is our response from security? What is our response from the internal actors that would be involved in a disaster like this? And then our external response is really looking at our external partners. So in the case of active shooter, again, we would say things like, what is our relationship with the Houston Police Department and local law enforcement that would be responding to these events? Now, this kicks out a relative threat, which, while it's a percentage, it's really not a percentage of the likelihood of this occurring, but it's used for ranking of these events. And we do this every year to identify what our both external and internal flood or our external and internal threats could be. So you would see for this year when we did this, our external threats were flooding. Now, what we've done and what we've seen since Hurricane Harvey is that we've devoted so much effort into planning of these events, in particular for hurricane, that hurricane has dropped dramatically on this list. And so this almost is akin to like a PDSA cycle and a quality improvement project, where we analyze the data, we look at things, we develop our plans and procedures, push those in the direction of what we think our highest threats are, and then hopefully see that threat decrease on that list from that number one rank lower on the list as we've implemented plans, done drills, revamped our plans, and done training for our frontline staff. Our internal threats, things like active shooter, again, was high on this list at this time. We developed a robust plan training faculty and staff in run, hide, fight for active shooters. And as a result of that, along with increased presence of police and security on site, as well as increased relationships and improved relationships with our external partners, what we've seen is active shooter has dropped on this list and is no longer our number one internal threat. So this is a tool, I think, that can be very powerful in just framing what your true threats are and what you need to be focused on while you're thinking about preparing and planning for events. Specific to COVID-19, one of the things that I found very interesting is this is a unique disaster to respond to compared to things like hurricanes, active shooters, mass casualty incidents that we frequently drill on and plan on. And one of those is because of the length of this response. And you all know, as you've been embedded in this for over a year now, this COVID pandemic, that what we've seen is the response is so much longer than many of the disasters that we generally plan for. But initially, we weren't really sure where to start and what the framework should look like in that response. There were some early thoughts put together about planning phases, different phases. We talked about having an initial task force, which was set up early in the pandemic. And you can see this is an intentionally busy slide where we talk about all of the various pieces of our response and what that would look like. So we were kind of reinventing something that we've done and used and leveraged in historic events quite successfully, which is incident command. And so the incident command structure is what we use when we have a hurricane, for example, come. But we weren't using those same principles for COVID. And we realized, why are we doing these task force? Why are we building this whole new infrastructure when we have something that's proven to work in past events? This is a kind of basic overview of what an incident command system could look like, where you have folks like your public information officers, liaison officers, safety officers, but then you have subcommands overlooking clinical operations, planning, logistics, all of the various entities that would be involved in that response. And so what evolved out of the early days of our response to the pandemic was our COVID-19 Operations Command. And we've actually had, I think, 4 or 5 different commands that have come up and been stood up and then stood down as the course of the pandemic has come along. So looking in March of last year, when things were on lockdown, we opened, for example, our Reopen and Redesign Command, where we address ways to get people back to our facilities safely, with pre-testing, with screening, all of these things that we could go back to somewhat normal operations on a clinical side while making sure that staff and families felt safe coming into our facility. Another thing that we did early in the pandemic, and I highlight this because I think this is something that a lot of children's hospitals did and probably didn't need to do in hindsight, was we developed, specific for COVID-19, a mobile pediatric emergency response team. And this is something that historically Texas Children's has done. We deployed a similar, and I'll call this MPERT for the sake of this talk, but a similar MPERT to respond to the displaced persons mega shelter at the Astrodome in Houston, a large sports arena complex, after Hurricane Katrina. So there were thousands of people from New Orleans that were in a mega shelter in Houston. Many of them were children, and there was no medical home for these children. So we deployed a mobile pediatric emergency response team, essentially a mobile pediatric clinic that was embedded within the shelter that provided a medical home. And in the course of 2 weeks, saw over 2,400 children that likely would have been put in ambulances and brought to our facility had we not gone to them and provided that frontline low acuity medical care that they needed. We did something similar during the H1N1 pandemic and turned a parking garage in our main campus into a clinic where we could see patients presenting that were, again, low acuity but high likelihood of having H1N1 or flu-like symptoms, where they could be seen, receive most of the services they would receive in the emergency center, but never even needed to enter our facility. So we developed these alternative care sites during the pandemic, expecting some sort of surge of, albeit low acuity, but high volume of patients that were going to be presenting, requiring testing or requesting testing. But our facilities look much different than they did during H1N1, as we now have 2 additional community sites. We have a pavilion for women and a large urgent care network. So those things all needed to be taken into account. Obviously, you need to think about system triggers for something like this, and we identified numbers of what our routine arrival patterns for our emergency centers look like and what would push us to a point where we thought we needed to open this. And in the end, we ended up seeing the exact opposite. We saw a great decrease in our number of EC arrivals, in particular for pediatrics, and very low volumes throughout the pandemic. And we've only recently started to get back to our pre-pandemic levels and beyond, actually. One of our sites had a record number of EC arrivals last week, which is, I think, showing that things are, from a pediatric perspective, children are going back to daycare, children are going back to school, and so we're seeing much more of those sick visits that we were not seeing earlier. So this is this parking lot that I mentioned that we turned into a clinic, and this is a picture of what it looked like after we redid it. So you can see 10 patient care spaces, 2 waiting areas. The waiting areas had videos that we recorded that gave discharge instructions on COVID on repeat loop. Very no frills, but able to do most of the testing that would be required for these type of patients. We got a little bit creative in one of our community sites and used this long snaking hallway to develop a similar alternative care space. As you can see here, this is our West Campus MPERT. So 8 patient sites, 1 procedure room to do things like cath urine specimens. And then our Woodlands campus, interestingly, had this large waiting room for radiology that was nearby the emergency center that's actually oddly negative pressure, the entire room is. And so we were able to use that and turn that into, again, an 8-bed clinic space. Now, we never needed to use any of these spaces. Our volumes have been low throughout much of this pandemic. They're only now getting up to, again, pre-pandemic levels. But it was an interesting exercise in alternative care spaces. And we've utilized a number of these things that we implemented and created for this to do vaccine rollout. So this radiology waiting room space has not been used for vaccine rollout, but all of the pieces of this puzzle that you see in this picture have been used for our vaccine rollout for our patients that are eligible for vaccinations. We did buy tents and other things and tried to figure out how we could expand our capacity, but ultimately these internal locations seemed to be more comfortable for patients and providers. And so we did not end up using any of these other than for some of our drive-through testing. And you can see this is a setup of these tents that we purchased. But again, they're cumbersome, they're challenging to work in for clinicians, and we ultimately did not go that route, but never needed to use any of these specific for a massive surge of patients. Something that, again, looking historically at what we've done, and we took a lot of lessons learned from the Ebola pandemic, was what can we do to do patient screening, things like personal protective equipment, all of these things we kind of went through our first iteration with Ebola and looked at these process maps as far as how do we identify patients, how do we screen patients for COVID-like symptoms, what do we do with those patients? And this was essentially mirrored what we were doing during Ebola. And I liken this current pandemic to Ebola and kind of morphing into H1N1. When what we saw was early in the pandemic, there was a large stress on travel history, And then it morphed into more system or symptom-based history as things became endemic to our region, and it wasn't so much travel-based that we were having concerns. And so that screening piece really evolved over the course of the pandemic from travel to symptoms. And then what we've seen in children is high numbers of surveillance testing positive, either asymptomatic or with symptoms that you would not necessarily attribute, at least early in the pandemic, to COVID. I want to talk and frame a conversation about personal protective equipment because I think it highlights many of the challenges that we face during this pandemic, in particular related to getting equipment from a facilities and logistics and supply chain perspective, as well as the communication to frontline providers as to what things are going. So early in the pandemic, and early in the pandemic when social distancing became a thing, we decided we needed to revamp things like our waiting areas. We went largely to virtual waiting rooms when we could, so people check in online when they're at the facility and then are notified when their room is available. Obviously ramped up largely our telehealth exposure, but a lot of this became very challenging because things were changing very frequently. And one of the things that was extremely helpful, I think, early in this was partnership across the Texas Medical Center through all of the institutions that were present to making sure we were aligning policies. So things like visitation policies, things like number of parents allowed at bedside for patients, all of those things were being made a very high level discussion across all of the institutions to make sure that they were all in line with each other. And we were all kind of comprehensively approaching this problem together. But again, when guidelines are frequently changing, as they were during early in the pandemic, we had multiple PPE guidelines that were rolled out. And how do you get these things in front of the frontline people that are doing the work? Communication is a challenge. There are multiple emails sent every day about updates to some of these policies and plans. And what we recognized was probably our best effort was doing group huddles very frequently with frontline providers. So daily huddles at shift change with physicians and nurses to update policies and plans. A website that contained all of the information for our institution that was the source of unified truth for our institution that was updated in real time when these things were being done, as well as, I think, informal huddles that were done. So as an example, for our section of emergency medicine, twice a week, I led Zoom meetings where providers were able to log in and discuss things with me, present questions to me, where we could talk in real time about what the challenges were they were facing and their concerns and worry, which I think is an extremely important thing to have people have a forum to express those things in some sort of meaningful way. And what we identified was that eye protection, as well as extended use N95, so a single N95 that we wear throughout our shift. We put a surgical mask over it and change those out in between patient encounters, in particular if they get soiled. It works. And when we started doing this, as well as universal masking, even outside of patient rooms, what we saw was our employee health numbers drop dramatically. Our supply chain folks at Texas Children's have done a tremendous job during this pandemic, and I think that they must be among some of the best in the world at what they do, and that we have an embarrassment of riches when it comes to personal protective equipment. They set up a goal to have in-house over a year's worth of days on hand of PPE, and they've really hit those targets for a number of the things that they were trying to procure. And again, going back to the relationship with the Texas Medical Center and the other nearby organizations, we realized that there were some things that we were able to get, but other places weren't, and vice versa. And so we did do sharing of supplies among those institutions, which I think was another great strategy to beef up some of our supplies and also assist some of our partner organizations in the Texas Medical Center. And ultimately, like I said, what we saw was dramatic decrease. If you look at this red line at the bottom of this, when we started doing universal masking and universal PPE, our employee health numbers dropped significantly from a positivity perspective. Many of our providers were not getting COVID from patients, but getting COVID from coworkers. And when we did universal masking, this number dropped significantly. So the PPE works. We wear it for all patients. And I'll touch a little bit about why in a second. We wear it for all patients in an effort to protect ourselves. Another emergency management principle and disaster medicine principle that I think is helpful in simplifying these complex problems is something that we in disaster medicine refer to as the 4 S's. And any problem can be approached looking at this. And I think it's very helpful for me in the midst of things like a hurricane or our most recent winter storm or other things to think about these 4 S's. And those are staff, space, stuff, and structure. So staff is really thinking about who do you need to be working? Who do you need to be there for a response? Space is what space are they going to be looking at? So if you're looking at a surge of potentially critical care patients, what sort of space do you have that you could use alternatively, like post-anesthesia care units, pre-operative care, to use for critical care space. Stuff would be, again, those supplies, so things like protective equipment, testing supplies, etc. Structure is really your policies, your procedures, those algorithms and guidelines that you're going to lean on to provide a response. I want to use those 4 S's. I'm going to talk about what we did related to COVID testing and apply those 4 S's to that in particular. So we were given the charge to start doing employee health testing, so testing our employees that were sick or exposed. And we had a less than 24-hour period to turn that around.
Brent, can I interrupt for a second?
Sir, yeah.
Yeah, can all the audience members please mute their microphones? We're getting a lot of interference. Everybody please mute their microphones. Go ahead, Brent.
Thank you. So we identified staff that were available to do the testing. We leveraged not only our health nurses, but also other nurses and...
Sir, Kesini sir, you had to unmute yourself. Kesini sir, you had to unmute yourself. I have muted everybody. Gautam, can you tell him? Yeah.
Brett,
Okay,
can you unmute yourself? The organizers muted everybody to avoid interference.
Thank you. So we identified our staff that we needed, and then we had to identify our space. And so what we did was we identified a parking garage that we owned, and this was, again, set up in less than 24 hours with a tent, with a cooling unit, all of the supplies that we needed as well. The space, here's again one of our tents that we had purchased, thinking of it as a potential tent to be used for an alternative care space for surge, but we actually ended up using it for drive-through testing. And then stuff. So here's a very unflattering photograph of me testing a 3D printed nasopharyngeal swab. We had huge challenges in getting nasopharyngeal swabs for testing. And so we actually rolled out 3D printing of the pediatric nasopharyngeal swabs and have been using those in our clinical practice to test children under the age of 3, as we're unable to procure any nasopharyngeal swabs for those smaller patients. And structure, looking at what you have in place as far as identifying what metrics you need to measure, et cetera. So this is an example of one of our daily reports that we get on our positivity rates. So you can see all of the various locations where patients are tested, what number were positive in that last 24-hour period with percentages, and then track our positivity as we look across 7-day averages throughout the organization. And in total, to date, we've tested over 100,000 patients through our drive-thrus. So 100,000 patients have received testing either for surveillance before presenting to the hospital for a sedated procedure, for surgery, what have you. Received testing when they've become symptomatic, largely having telehealth visits with their primary care providers and then being referred to the drive-thru for testing. And this drive-thru operation that started with that simple tent in 24 hours for employees has now taken on the burden of about 80% of the testing that we do daily across our entire system. So the keys to our success, I think, really focus on the rapid mobilization and flexibility of resources and staff. So these are, for example, the testing, these are staff that were not, this is not their day job to go to a parking garage and provide testing for patients. Also, rapid acquisition of PPE and training for PPE for best practices, maintaining safety, cohorting identified patients with COVID, and then leveraging, I think, technology and innovative solutions. So we've kind of expanded our drive-through operations to do much more than just testing. For example, our dermatology clinic has a drive-through clinic for wart removal and other minor procedures. Our ophthalmology clinic has a drive-through system set up in place to dilate patients' eyes prior to their visit, so that they don't need to sit in the waiting room for 30 minutes to an hour after getting their dilation drops for their exam. All of these things have, I think, made it where we've been able to practice what we do in a safe manner, protecting our staff, our faculty, and our patients and their families. Some of the ongoing challenges that we've been faced with is clearly we've all faced some degree of COVID fatigue dealing with this. I think we all are eager to get back into rooms with each other, to get off of these Zoom and Teams meetings and things. But I do say that some of this has been a bit of a blessing in disguise, and that it gives us the opportunity to speak with colleagues across the nation and across the world like we are today, virtually, to provide, I think, insight into the challenges that we've faced. We continue right now to see steady low numbers of positivity in children, but we have seen increased incidence of severely ill children during this phase. So while our overall numbers are low, they do seem to be sicker, the children that we're seeing. And we have had a large number of children with MIS-C that have presented to the institution, some needing ECMO and other interventions that are pretty significant, many needing ICU level care. Our future challenges, we've been somewhat blessed this past year to have really no flu, but we anticipate that this upcoming fall, maybe even summer, what we've seen is other institutions in other places seeing large surges of RSV in the summer months, which is unusual for us. We anticipate seeing this surge. And what we've seen in our front lines in our emergency centers is a large number of children with viral illnesses outside of just COVID. And I equate this to kind of, what we call kind of the daycareitis phenomenon, right? So we know that children, when they're first exposed to a lot of other children, whether it be in daycare or schools, they have on average 20 febrile illnesses in that first year. But children have not been in that environment for the past year. And so what we're seeing is kind of a compounding effect of those children getting back into daycares, where we're seeing these high numbers. Right now, what we're seeing is a large number of norovirus patients with gastro-like symptoms coming in because they've been so isolated in this past year that they're all kind of presenting into that situation at once. And then, of course, we've most recently had to deal with our winter storm. This is something that wasn't necessarily in our playbook, falls under, I think, our planning for extreme weather event. But we were faced with a number of challenges. And while I think the institution doesn't like it when we don't really hit it out of the park and do a terrific job in our response, I like it because it highlights where the challenges are, where the barriers are, and where we can make improvements to be even better than we already are. And with that, I will close and open this up for questions and discussion. I'm very eager to hear from you all about the challenges that you guys have faced. And I hope that some of these basic emergency management principles may help structure some of the challenges that you guys are dealing with currently. Thank you.
Thank you so much, Brent. That was an excellent overview of our own challenges and how we stepped up to deal with them. So let's hear from the audience members now. We have participants here on Microsoft Teams and also watching on YouTube with live streaming. So we really want to hear your questions. What comments do you have? Anything you want to ask Dr. Kazini? You can either chat them in or speak, unmuting your microphones.
Sir, I think, Gautam, we can go ahead. I mean, after your talk, probably we'll do that one.
No, this is it. I'm not
Jagdish,
giving any formal lecture.
Somebody has raised the hand.
Yeah, go ahead.
Who is this?
Can I say?
Yeah, please, go ahead.
Yeah, it's a excellent presentation, sir. I just want to know, after the COVID, post-COVID, what is the planning you have done for children? Is that a part of this, or this was more for the acute phase? That is what I gathered. Thank you.
Yeah, so I think, thinking about, and again, this is somewhat of a focus on some unknowns that we still have, I think, dealing with this, which is some of the long-term effects of COVID on children. What we've seen, I think, I'll take it kind of through a kind of clinical course of a child, right? We have seen, a fair number of children that have been acutely ill with active COVID and acute COVID, but probably the sicker of those children that we've seen has been in the aftermath of that. So, about 4 to 6 weeks after COVID infection, and many of these children didn't even know they had COVID. They were asymptomatic or had minimal symptoms. We've seen them presenting with MIS-C, and those children can present quite ill. This lags what we see as global surges in our communities as well. So if you look at our global numbers and our numbers throughout the Texas Medical Center and the region, when we see a large spike in COVID infectivity rates, when we see a large spike in positive cases, there is this lag, 4 to 6 weeks. That's when we start to see patients with MIS-C. And those children can actually look well, but actually be quite sick. We've had a number of them that have been found to have significant hypotension, cardiac involvement, cardiac dysfunction, and have required admission to our ICU as well as our CVICU for pressor support, et cetera. But then beyond that, even, I think moving into the next phase of this, what are the potential long-term effects? And so working with our network of pediatric clinics that we have, we've done things like working on return to sports for sports clearances, cardiac evaluations as needed for those that had active COVID or have concerns for any sort of other issues. And so we're, again, I think, looking at this kind of long hauler phase of COVID from not just those that may have had minor illnesses, looking at things like returning to sports, but also those that were more impacted, either needing admission for acute COVID or MIS-C, going into like for lack of a better term, I call our kind of long haul clinic. So we have follow-up with specialists, in particular our rheumatology colleagues, et cetera, that are following those patients long-term to see what the potential long-term impacts of COVID have had on them and their health.
Thank you, sir.
I see Dr. Chinappa has raised his hand. Go ahead, Dr. Chinappa.
Dr. Brent, that was a fascinating lecture, and thank you very much for your experiences at Texas. I had just 2 queries. One, this hazard vulnerability analysis. How often do you do it? And this looks like a proactive step to define what challenges you're going to face through the year. So do you do this on a regular basis? And is there any small group which looks at this? And is it only your institution specific, or do you look at area specific? Like, for example, in our situation, the government decides what is going to be the disaster management plan for the state, and the hospital is left to manage its own kind of disaster management thing, which is very rudimentary. So how does this work? So that's one question.
Yeah, it's a great question. I think one of the things that we do, to start off at the beginning, we conduct these HVAs annually. So every year we conduct the HVA for each of these institutions. So again, our medical center campus, our West campus, our Woodlands campus, they each have their own HVA. Our health centers have their own HVA. Our outpatient clinics and urgent cares have their own HVA, as well as our health plan, which is an insurance health plan that has thousands of children in kind of the greater Texas region. We do this annually, and the folks that we invite to the table are largely the leaders within those respective institutions, as well as members of our emergency management committee. So another thing that I don't think I didn't really stress or touch on is we have an emergency management committee that is leaders from areas like the OR, nursing leaders from the OR, ER, ICU, as well as physician leaders, as well as leaders in things like facilities, facilities management, security, supply chain. So they meet annually and go through these HBAs every year. And again, for me, I use it in my position as medical director of emergency management to push emergency management in the direction of what we see as our highest threats. We've been able to successfully, through pre-planning, preparedness planning, drills, and education, mitigate our risk for what are really our most common threats, like hurricanes. So again, it's not our number one threat if you look at it, and it may be confusing to somebody. Well, you guys have hurricanes all the time, you deal with this all the time. We do so much robust training and work on hurricane preparedness. You actually feel very comfortable that we are able to manage that type of event. Whereas if you look at tornado is now one of our number one threats because it's something that happens frequently, but not frequently enough to impact any of our facilities. But if it did, it would be extremely impactful. And we don't really have a robust plan in place, haven't done training. So this year, we're kind of taking on tornado as what we're going to highlight some of those efforts on and hopefully push the needle to improve. And then hopefully those scores in that far right column will go to 2s or 1s, and we'll see it drop from the top of our list. We don't, and these are very institution specific for us. So there are regional HBAs that occur. Those are usually done by what we have in Texas, our regional advisory councils that serve as kind of our disaster coalitions. And so they do those HBAs as well. And we usually kind of look at theirs to see if we're in alignment and there aren't any odd outliers. You know, one thing that was kind of a bit funny was we did our HBAs for 2020 before COVID was really on people's radar. And Joint Commission came well after that. So we actually went back and added pandemic preparedness to our HBA because we thought it would be odd if an accreditation institution was looking at our plans and saying, pandemic's not even on here, we're in the middle of this global pandemic. So we had to then have another conversation about where pandemic fit in. And we actually have two kind of related threats. One is high consequence infectious disease, so thinking more along the lines of Ebola, and another is pandemic. And those are separated because I think there are unique challenges to each of those different types of events. But excellent questions. I hope that answered your question.
Thank you. Thank you. Yes, it did. Thank you.
Sapare?
Next question,
Dr. Sapare?
anybody?
Dr. Sapare? Dr. Anil Kumar Sapare, are you there?
Yeah,
Yeah.
yeah.
Yeah, please.
I was just wondering. There is a big talk about a third wave that is going to come in November, and this is going to affect significant number of children's over our country. India has got a very large population of children. They remain more vulnerable because they are not the ones who are vaccinated. What do you recommend we should keep a plan of action, just like what you recommended, the actions you have taken in our scenario to mitigate the problem in pediatric population?
You know, I think one of the things that we were fearful of was looking at data out of the UK with the UK variant. It seemed like it was impacting children more, it was more impactful in children, making them sicker. And to date, we have about 80% of our patients that are testing positive for UK variant. So it's definitely the overarching variant that we're seeing right now, but we aren't seeing that marked increase in severity of illness in those children, albeit we may be seeing higher numbers of MIS-C. I mean, I think what we've really realized is that the MIS-C patients are the sickest of these COVID impacted patients. And so what I think, and what we do, I'm on every other week calls with our public health colleagues, our epidemiologists, and folks that are embedded in public health for our region. And what we pay very close attention to are, again, community surges. So seeing when there's high rates of community positivity, high number of community patients, look at pediatric specific surges. And then we look at, again, monitoring that 4 to 6 week period after those peaks is when we anticipate we're going to be seeing the presentation of these MIS-C patients. And recognizing that there could be, we haven't to date had this or need this, a run on again, the critical care components of their care that may be needed, like ECMO. We don't have a ton of ECMO circuits, even in the Texas Medical Center, the largest medical center in the world. And so paying attention to those trends to prepare us for eventual potential influx of very sick kids is what we've been doing. I think it also highlights something that's important to do, early in these things, which is identify altered standards of care, crisis standards of care. And that's something that we as an institution did through our ethics committee, and identified what patients, if there's a run on ventilators, a run on ECMO circuits, et cetera, what patients would we be prioritizing to get those interventions in a resource limited setting. It was extremely challenging to have that conversation with physicians that work at Texas Children's, because I think we have, in general, an embarrassment of riches when it comes to these sort of resources. It's very hard for a physician to kind of put themselves in the mind frame of working in a much more resource limited setting where you don't have kind of anything and everything you've ever wanted. But we were able to do a brief tabletop exercise to kind of frame the conversation, present the challenges of a large influx of children, all critically ill, et cetera, to kind of set the stage for that conversation with our subspecialists. And I think it was extremely helpful to do that up front to get them in the right mindset to address the problem. And so we developed some alternate crisis standards of care for our institution that we have been fortunate to not need to implement, but we have those prepared. And that's something I think is important to do before you're in the midst of this, is setting up that framework, that ethical framework for what this response would look like when resources become limited.
Thank you. That's useful information. Thank you.
Thank you, Dr. Paro. Other questions?
As of now, nobody has raised the hand, sir.
So I have a couple of comments. Brent, I think it would be useful to explain exactly what incident command is, how it is set up, and how it functions.
Sure.
Go ahead.
Yeah, so what most hospitals in the United States use is something called the Hospital Incident Command Structure. But ICS in general is something used by fire departments, emergency management organizations, disaster response teams. And it really is just setting up a internal hierarchy to the response with targeted, action items for each of those subcommands. So we have our incident command. Our incident commander is, and the structure here at Texas Children's is every week we have an administrator on call. So there's someone, an executive vice president or somebody in an administrative role that is on call to deal with whatever challenges come up in the middle of the night, over the weekend, what have you. But if there is a disaster, they go into the role of incident commander. And we have our incident command with our sub-commands, which do things, like facilities. So they're looking at keeping the place clean, keeping the place safe, looking at, supply chain issues that arise, making sure all of those things are in place. So for a hurricane, for example, they pre-position supplies like diesel for our generators, tanks with potable water, et cetera. We have operations, which is really our kind of nursing focused clinical operations command, logistics, all of these subcommands. And here's a picture of our incident command center from Hurricane Harvey. We've had to, I think one of the challenges of COVID is that if you look at this is obviously not what our incident command looks like during COVID, right? Tons of people in a relatively small room, maskless, no social distancing. And so what we've had to do is kind of pivot that command into a structure of a virtual command environment, where we started with something akin to what you just saw in that photograph. Then we started with that room, but socially distanced with universal masking. Then we moved into a larger room where there were more people socially distanced. And now we've gone largely to a virtual structure for this. But I think the importance of it is everyone knows what their job is and they know what they're responsible for doing. And then incident command has oversight to make sweeping changes rapidly to impact the organization. So an example of that I would say is if you look at our reopen and redesign command, we made the decision in that command to make MyChart, which is our app-based Epic electronic health record for patients, universal. All Texas Children's patients need MyChart. That's a decision that probably would have taken 6 months to a year to be made for our organization and institution under normal circumstances. But having all of those key decision makers in incident command and embedded in that command makes you able to make these kind of unilateral quick decisions that impact the entire organization and make a large organization much more nimble than they are during normal operations.
Great, that's very helpful. Any questions, Ravi Shankar?
No, sir. No.
Okay, so I have one more comment or question.
Aarti, once again, Dr. Aarti, do you want to ask once again?
Yeah, can I ask, please?
Yeah, go ahead.
Please go ahead.
Go ahead,
Yeah.
Aarti.
Yeah. I just wanted to know, like, what can you give us some tips as to how we can convince our administrators that the preparedness of this magnitude needs to be there to have a better outcome of patients? Because we have a little different system over here in India. So can you just give us some inputs on that, please?
Yeah, I mean, I think this was a challenge that I had early on in my time back at Texas Children's. And while I highlighted what I think is their, forward thinking and interest and dedication to emergency management, there were still a lot of gaps and a lot of shortfalls. And I think, two things, and one was kind of touched on earlier in the conversation, and then another one. And one is that the work of emergency management needs to be something that everyone is familiar with in administration. And so what we've done is we actually have a emergency management primer for director level and above within our administrative structure, where they do a 2-hour course to learn about what emergency management does and what their focus is. So I think that increased awareness and knowledge and some background in emergency management is extremely helpful to pushing the agenda when they see the importance of this structure. It's just like when we saw early in COVID, this task force that we had developed that was not an emergency management structure. And then it was kind of a chaotic mess with all these different work groups. And it took kind of somebody taking a step back and saying, emergency management should be owning this. Emergency management and incident command should be running this. And things have gone much smoother since then. But I think ultimately what a lot of the work that I was doing earlier was really early in my career was really convincing I think leaders of the hospital from the kind of executive administrative side, the importance of this work. And so I think it really is about highlighting the importance of us being there for our families, our patients, our community, and highlighting how impactful from a business operations standpoint some of this stuff can be. At least here, a lot of this is business driven. As much as I hate to say it, it should be mission over margin, but a lot of times things are margin driven. And so identifying things that are going to make sense for the finances of the institution are extremely helpful in at least my talks with administration to get buy-in from them. And then the other thing is just recognizing, I think, things that we can leverage that are emergency management driven, but can be implemented in daily practice. So an example I have of that is we have two-way radios that we use in the event of a disaster. We did disaster drills in the emergency center, and the nurses loved their ability to communicate very rapidly with each other across our large emergency center, and now actually use those two-way radios daily. So finding things that you would implement or use in a disaster, but finding a daily use for them is something that I found to be in particular helpful and advantageous in convincing administration to buy into some of this stuff. Ultimately, it comes down to convincing them of the mission, and that doing the best to do the mission is going to require some of this forward thinking and preparedness. thinking that it's not going to happen to you is kind of, an old adage, like an old concept, because it's happened to all of us this past year. And if anything, I think this pandemic has stressed the importance of disaster preparedness and planning, because we've all been impacted. We see time and again institutions that are impacted by an event and then they get better, but it's not something that's an ongoing structured thing. I once talked to one of these surgeons that was in Orlando Health after the Pulse nightclub shooting, and he essentially needed to text and call all of the surgeons to come in after this, large scale mass casualty incident to come respond at the hospital. And two to 3 years after, they still did not have a robust emergency notification system in place for their institution. So they recognize the challenge, they recognize the problem, but haven't been able to push the needle to implement the changes necessary to do better next time. And those are the sort of things, I think, highlighting those things to administration. It's kind of like, let's not make the same mistake twice, are again advantageous when you have these conversations with hospital leaders.
If I can add on to that, I think we should emphasize that NABH accreditation will be facilitated if there's good disaster management operations. The other thing is, when you talk to the administrators, you should emphasize that you can avoid negative media attention, because you don't want to be the hospital where there's a disaster and patients die because you are not poorly prepared. So that will get their attention.
Yeah, I used to have a kind of elevator speech when I had any FaceTime with hospital leaders, and one of the things I would highlight was, if you look at the Boston Marathon bombing, there were no in-hospital deaths. And think about if Texas Children's had the only in-hospital death because we weren't prepared for an event like that. Something similar to the Boston Marathon bombing happened in Houston, and all the other hospitals did great and we didn't. That would really kind of hurt the reputation of the institution. And that's something that I think really resonates with hospital leaders. In healthcare, leadership can be extremely reactionary. So something happens and they want to do something immediately. We planned a large-scale mass casualty drill for our institution years ago, and it took 2 years for me to plan it, to get buy-in from the administration to do it. But the day after the Paris attacks happened, they were like, we need a drill like this and we need a drill now. And, I said, we've been working on developing this drill. We're going to do the drill, but it's going to happen in a couple of months because that's when we planned it. So again, I think it's kind of, calming the reactionary nature to some of these events that happen in other places, but also stressing the importance of not letting our communities down, not getting that negative publicity, negative media that's going to ultimately impact finances. So if you look at the hospital in Dallas Presbyterian, that had the Duncan case during the Ebola epidemic, their finances were ruined after having that case and after having 2 nurses get Ebola from taking care of that patient. So we took the approach of, we are going to do everything we can do to take as good of care of Ebola patients in a safe manner as possible, to reassure our community that we are doing everything to keep them safe, in addition to our patients, their families, and our frontline providers. And that's what led ultimately to the creation of our special isolation unit, our 8-bed biocontainment unit. So you can kind of run towards the problem and get ahead of it, or you can run away from it and think it's never going to happen to you, but the likelihood is it's going to happen to you. So I think that's another helpful tip in talking to hospital leadership about these issues.
You've all heard the saying, strike when the iron is hot. The iron is hot right now. Nobody can deny the presence of a crisis and a disaster and the need to be prepared. And if the least you can do is be prepared for the third wave and apply these principles to the current situation, I think this session would have been a success. So, Brent, one more question I had, and based on my observation, is one of the things I saw in the Texas Medical Center is the leaders of different hospitals really collaborating, working together, and they had conference calls once in the morning and once in the evening. So how can leaders work together, leaders of different hospitals? And some of these hospitals are competitors. They're trying to divert patients from each other so that they can make more revenue. But yet during a crisis, they collaborated. How did that occur? What are some tips that you can share?
Yeah, and this happened, I would say kind of coalition impact, kind of coalition effect happened in a couple of different ways in parallel. And one is, again, and I mentioned very briefly, our regional advisory council setup that we have in Texas. And in our region, that's run by SETREC, the Southeast Texas Regional Advisory Council. That's been a long-standing organization that's our disaster coalition that brings a lot of these institutions to the table to work together to respond to things like Hurricane Harvey and other disasters. Having that in place really has already led to those existing relationships to working through these disasters and events together. But what we kind of took it to the next level during COVID, where we saw, hospital CEO level, high level hospital leaders, both clinical and administrative, getting on these daily or twice daily calls. And part of that was really making, again, and I mentioned this briefly in the talk, making, again, kind of a cohesive, aligned strategy in approaching things like patient screening, visitation rights, PPE guidance, all of those things. I think where when you're going to go to a hospital in the medical center, your experience is going to be relatively similar regardless of what hospital you go to from a COVID perspective. You're going to see people wearing sort of the same stuff. You're going to have the same screening, and it becomes rote and it becomes known to the community that this is what's going to happen when you go to the hospital. It would be a challenge if, we were not allowing any visitors and someplace else was allowing one visitor at the bedside or something like that. So it's really, I think, was recognized as important for these institutions for us to all be a singular voice. And you saw a number of, kind of media spots, formal letters to the governor or the mayor, all signed by the CEOs of the hospitals within the Texas Medical Center, saying that we are all on the same page. We are the healthcare experts in this, and we are saying this is what we should be doing. And I think that's extremely impactful, when you think about getting all of these people together. But we have a history of working together through disasters. We've been through a lot of disasters together. And so I think we recognize when push comes to shove and when things are really tense, we have to work together as partners. And it's been helpful. As I mentioned, kind of some of the sharing of personal protective equipment that's occurred. Those other things can be extremely helpful to all the organizations involved. And so it's not like you're just giving, you're also getting in return. And I think that give and take is extremely important.
I think one of the important principles you're emphasizing is that essentially practice makes perfect. I bet you when the first hurricane hit in the 1950s or 1940s, people were not as prepared as they are in 2021. So it takes a few rounds of going through some experiences to become better. And one implicit thing that comes out from your talk is that even in a chaotic situation like a disaster, if you have a plan and if you have a organized method of approaching the crisis, it introduces a sense of order and control in a situation where you feel like you have no control. It's a bit like running a code, like when a patient has a cardiac arrest in the hospital, it can be total chaos or it can be very systematic. You follow the ACLS algorithm or PALS algorithm, and that gives you a sense of order and control, even when things are not completely under your control. And I think that's one of the important points that I'm picking up from your presentation, that there is a way to manage things in a very systematic, structured way.
It's a great analogy. You think about the team lead as the incident commander and the various sub-commands as the others at the bedside doing their dedicated tasks. I really like that analogy that you make. And it's important because when we know, those of us that have been in poorly run codes, they're loud, they're noisy, it's difficult to communicate. And that would be just like in a disaster response, right? too many mixed messages, too many emails, phone calls, text messages saying competing things, or having, again, that structure, in particular with communication, it's always a challenge in disasters, event like this. You know, when you talk about practice makes perfect, I think another thing that I very frequently stress in my talks is the importance of doing drills. And that's because you don't want to just wait for an event to happen to get better at it and practice it. And so doing drills, setting up drills, is extremely valuable to do. I think what I've learned kind of in my experience is that we used to, and everybody coming to the hospital and kids with moulage and all that stuff. And that is extremely resource intensive. It's extremely disruptive to normal clinical operations. But tabletop exercises, just sitting down with a scenario and a series of injects that present challenges through an event with the leaders of the hospital in various impacted areas, can be even more beneficial and much less resource intensive. When we did that drill that I talked about that took a couple of years to plan, you know, it was a great drill in that I think it showed the institution that we could pull something off like that. We all patted ourselves on the back and said we did a great job. But what did we really learn from it? Probably not a whole lot. But we did spin-off tabletop exercises using the information gathered from that drill, specific to groups like radiology, pathology, the operating rooms. And I think those tabletop drills, we actually got much more granular, helpful detail to improve our plan and our response to a mass casualty incident. So don't think that to do a drill, you need to have 100 volunteers with makeup on, simulating their injuries and all this stuff. Really, you just need the right people in the room to work through what the response would be like, identify what those challenges might be that present themselves, and then work on solutions to those problems.
Excellent. Thank you. Any other questions? Any comments? People want to share their thoughts?
I didn't see anything, Gautam.
Okay. If that's the case, I think we are ready to wrap up. And I'll hand it back to you, Dr. Ravi Shankara, Nagalata, and Sumita. Yeah, Brent, one more point.
I just want to say thank you again for having me. I hope this has been helpful. I wish you all luck in dealing with this ongoing pandemic as it unfolds in your country. And if there are added pieces of information that people would like or additional resources, feel free to reach out to me via email, and I'd be happy to share what I can to try to help you all.
Thank you so much, sir. That was truly an eye-opener for all of us. Lot of information and lot of insights. I think IPBPS is planning to have an action plan by next week. They have called for a meeting. I think we will use all of these tips and then probably contact you also if required. It was not the regular webinar where we discuss the mundane things. It was truly an eye-opener, and it is nice to just see how we can be organized and be prepared for all the disaster, not only the COVID. Thank you so much for having this session. Ravi Shankar sir, closing remarks.
Nothing. Patients were affected. In the second wave, pediatric patients are affected with COVID, and with the prediction that third wave will be affecting more, have a plan put in force, and we'll send it to the government of Karnataka. And we'll see what exactly we can do that one. Thank you a lot, sir, for coming and giving the things. It is a recorded session, so anytime we'll go back and we'll see any other points we can have it. And thank you, Gautam, for suggesting me this one about a week back. So, and Dr. Kazini did a wonderful job.
Thank you, Dr.